Great. Good afternoon, everyone, and welcome to today's webinar, Visual-Spatial Management of Spectrum Disorders, where we will be discussing vision therapy's role in attention, stimming, toe walking, and other visual motor abilities. Vision therapy has a long history of successfully remediating a myriad of visual anomalies that are associated with the autism spectrum. Today, we'll be speaking to you from two perspectives. Dr. Alami, our presenter, will be discussing the clinical end of our work, including the evaluation process and therapy, while I myself will later be infusing some of the data and the research that the center, including myself and Dr. Melvin Kaplan, a pioneer in behavioral optometry, have worked on together. Before we officially get started, excuse me, I'd like to go over just a few items for today's webinar. It's being recorded and will later be available on our website so that you can view it again or share it with family members or friends if you wish. You'll also have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane on the control panel. Feel free to send your questions in at any time during the presentation. We'll be looking at them and collecting them, and we'll hope to address as many of them as possible during the Q&A session at the end. I'd now like to introduce our presenter, Dr. Larah Alami. Dr. Alami, a doctor of behavioral optometry, is a SUNY optometry grad, where she completed specialized training in pediatric and vision therapy rotations. Her mission is to spread awareness of vision therapy and its benefits in the neurorehabilitation of individuals on the spectrum and with various other special health needs. It's with great pleasure that the Center for Visual Management offers her services, her specialized training, and her skills. And she's very eager to share that with everyone now. Dr. Alami, please take it away.
Hi, everyone. I'm so glad to be here today. A little bit of history about myself and my role here at the center. I've been here now about 2 years. And I work here part of the time, and the other part of the time I own my own practice in town as well. But it's really at the Center for Visual Management that I focus on vision therapy and what we can do for kids. So I'm really excited to be here, and I'm so glad that I found the center and that they found me. So to start, we're going to ask you to participate in a very brief demonstration. Look around the room that you are sitting in. Now, close your eyes. As your eyes are closed, we ask you to consider what other sense gives you as much information as vision. Think about this question for a moment. What other sense gives you as much information as vision? Many of you will realize that vision is our dominant sense, and although we can get by with listening or touch, we really can't grasp nearly as much information in as short of an amount of time. Feel free to open your eyes. So our objective tonight is to allow you, the parents or professionals or whoever's here, to identify key behaviors or delays that are associated with visual dysfunctions. We also hope to make you aware that vision therapy can be a very powerful tool in managing autistic spectrum cases. We're going to show a video of one of our patients now, and although I'm not going to comment on it too much or about what you're seeing, I just want you to watch it, and then we'll revisit this video at the end.
Emmy, can you take the spatula from there? This one. Can I have the ice cream? Be careful. It's really hot. It's really hot. Let's stand over here. I love your little smile.
Great, so we will revisit that very shortly. So, the brain devotes significantly more neurons toward vision than it does any other sense. The retina, which contains 150 million light-sensitive rod and cone cells, is actually an outgrowth of the brain. In the brain itself, neurons devoted to visual processing number in the hundreds of millions and take up about 30% of the cortex, and this is compared to only 8% for touch and just 3% for hearing. When neural conditions arise, many, if not a majority of children, will be prevented from interpreting or perceiving information from the world correctly. Therefore, the prevalence of visual motor and visual vestibular delays, poor communication and reactivity times, and underdeveloped social skills is expected to be higher. Some research has indicated that upwards of 50% of spectrum individuals can be diagnosed with a medical visual disorder, including strabismus, which is an eye turning in or out, significant refractive error, which would actually imply that 1 in 4 children on the spectrum are significantly not seeing clearly, or 20/20 as we know it, and amblyopia, otherwise known as lazy eye. And yet, vision is still one of the most wildly underestimated therapies out there. Commonly, visual defects associated with neurodevelopmental disorders include the inability to maintain eye contact or pay attention, issues with lights or spinning objects, peripheral side viewing, such as poor attention and eye contact, rocking, which many people actually do not realize enhances a person's awareness of space and depth perception, hand flapping, which encourages proprioception and where one's body is in space, and even toe walking, where the perception of the ground is skewed because of ocular and perceptual deviations. These behaviors are compensatory adaptations, and the responses we see from our pediatric and adult patients is often confusion, sometimes tantrums, and hyperactivity, and wanting to get a visually exhaustive task over with. As many parents come to find out, you unfortunately cannot rely on a traditional refraction or eye exam to detect visual processing concerns. Many of the parents and patients who come through our office are told that the person is seeing just fine and there's nothing wrong with their eyes, when in fact the child is having a significantly hard time paying attention. Parents might know something is off, teachers, occupational therapists. But still, if the trouble with eyesight is ruled out by a particular provider, a large population of physicians will feel that the vision is just fine. Unfortunately, a basic eye exam is just not enough. And in cases involving special health or learning needs populations, we strongly believe that testing the visual processing system should be a mandate before things like diagnosis or medications or surgery are begun. So, just as sort of a side comment, as an optometrist myself, and I own an optical myself, I myself, most of the time in my outside office, are just doing basic eye exams. So we're checking, is the patient 20/20, we check the ocular health of the eye. But in a normal eye exam, even myself, who is trained in vision therapy, I don't delve into all the sorts of testing we might be doing to see, are the eyes aligned properly, are there underlying issues? So, it's really important that if you suspect an eye issue with your child, or even if you don't, that a specialist who is trained in some type of vision therapy would be able to do an evaluation. So in addition to providing comprehensive eye exams in the office where we're examining the structures of the eyes, so for example, is the patient nearsighted, farsighted, are the eyes healthy, we employ a specialized battery of testing to determine how the neurological components involved in vision are influencing the individual's development, behaviors, ability to learn, and their emotions. These sensory motor diagnostic evaluations allow us to ascertain the muscle balance of the eyes. Is the patient seeing double, which, as we'll present in a few moments, is actually very common in sensory processing and spectrum disorders. As a result of seeing double, is the patient compensating by shutting down two-eyed coordination? And in these cases, you'll find children or adults have serious fears with objects coming toward them. So their ability to walk in open spaces like supermarkets or department stores, is, severely hindered, they may also have significant challenges going up or down stairs. The Kaplan nonverbal battery is unique to our office here in New York. Dr. Kaplan, who was the founder of the Center for Visual Management, was really the first to discover how Prism lenses and visual management could effectively treat visual dysfunction in spectrum populations. This battery of testing is the outgrowth of decades where once untestable patients were now able to be tested. The battery of testing largely emphasizes dysfunctions in ambient vision and allows us to examine individuals of all ages, even as young as infants, plus children, adolescents, adults who are nonverbal or who have other communication disorders, including patients who have experienced stroke or other traumatic brain injuries. So we really see a huge spectrum of patients, all the way from infants to the elderly. So what are these two-eyed coordination issues? You may or may not have already heard the terms convergence insufficiency or convergence excess. These are very popular type of situations that people might experience. Vergence or centering dysfunctions are one type of binocular vision disorder, and it's prevalent in processing disorders. Strabismus, this implies that an eye is turning inward or out. Your child's eyes could be switching, or it is just possible that the problem lies with one eye. For generations, we've heard many arguments that these disorders are not correctable, or not correctable after a certain age, like 8 years old or 12 years old. But in fact, we know better. We know that neuroplasticity allows a system the flexibility to change. We know that who we are today is not who we were 10 years ago, or who we'll be 10 years from now. Therefore, nothing is fixed or set in stone. With proper lenses and remediation, these anomalies can be treated without medication or surgery. By our calculations, specifically after analyzing data from 100 cases evaluated by our office, including both the nonverbal and verbal spectrum cases, 36 of these individuals demonstrated convergence insufficiency. That means 2 eyes have trouble coming in and remaining focused up close. 6 demonstrated convergence excess, where the eyes stay in too long and have trouble focusing outward. 28 individuals demonstrated exotropia, which is an eye turned outward, and 13 showed esotropia, which is an eye turned inward. And then the remaining 17 received no diagnosis. So to summarize this, 83 of the 100 individuals examined were found to have a visual anomaly inhibiting proper development or learning. Now, of the 100, we also saw 35 cases where the individual was able to confirm seeing double vision. In these moments and during these evaluations, it becomes so obvious to us clinicians, as well as the parents, that the children or adult will naturally avoid visual tasks up close. They will avoid making eye contact when pulling the eyes inward, because to do so can feel unnatural. By eliminating double vision in such cases, we can see a drastic decrease in the peripheral side viewing that we sometimes see exhibited by our patients, because they no longer need to block out one eye to eliminate the misviewing of the eyes together. In addition to binocular vision disorders, I quickly mentioned ambient vision disorders earlier, but ambient vision really deserves a great deal of attention here, because this is where we find major correlations between hand flapping, toe walking, and vision. When evaluating ambient vision processes, I'm observing 2 major factors. How is the individual orienting their body in space, and how are they attending to where things are in their space world? Orientation of body in space is evident in one's posture, the way they hold their head, their shoulders, their arm, their gait. Are they comfortable walking, or do they graze walls? Do they rise onto their toes for security? Information processing really requires accurate body schema. Therefore, a person or child who is comfortable in their space world will show fluid, comfortable posture and movements, while a person uncomfortable with their self will tighten up, rise up, keep their arms very close to their bodies. If a person is spending too much time and energy on where am I in space, they are left with much less time or energy for processing what and where things are in their environment. So how the individual eventually goes on to organize themselves in their world, whether they are active at home or on the playground or in school, or they decide they'd rather be spectators, this all originates with the view of their body. Secondly, how the person attends to their space world will be evaluated. A binocular vision exam tells us if the infant baby brings their visual system in and centered to make eye contact with their mother or father, but the measurement of ambient vision tells us if they can track their parents or caregivers as they move around the room? As toddlers, do they reach out for the toy in front of them? Again, a binocular vision exam can provide us with that status, but whether they are tracking moving objects or toys in space is again portrayed in ambient vision. Does the child try to catch or kick a ball, or do they try to keep up with the kids their age? As children grow older, they are expected to develop these appropriate skills, but when they don't, we can expect behavioral and emotional tolls. You'll see in Table 1 here that there's a comparison of focal vision to that of ambient vision. So focal vision, for example, is what is it? Object recognition. Ambient vision is where am I and where is it? Focal vision is static, whereas ambient vision is dynamic. Focal vision is involved more with the high resolution color vision, and ambient vision is low resolution, non-color vision. Focal vision involves only the central vision, whereas ambient vision is your entire visual field or your periphery. Focal vision becomes poor at night, and ambient vision is not poor at night. Focal vision is largely conscious, and ambient vision, which we mostly work with, is largely unconscious. Focal vision works in isolation, whereas ambient vision integrates with other sensory systems and limbs. Focal vision is innate rather than learned, and ambient vision is largely learned, and thus can be greatly enhanced through support of visual-spatial therapy. So in most eye exams, the focus is really on the focal vision column, and we don't really delve into the ambient vision side unless we're suspecting a problem. And even if your average eye care provider recognized that there was a problem with focal vision, they might not have the tools or the equipment or the ability to focus on ambient vision and really do the testing for that. So, I urge you to seek out a vision therapy provider who could do a full evaluation of not just focal vision, but also ambient vision. So we'd like to use this bell curve to describe visual performance a bit further. At the top of the curve are individuals with optimal visual performance. No one is perfect, but there also aren't disorders of vision impeding in the day-to-day functioning. How far an individual begins to perform from the standard deviation or the norm indicates to us whether that person is experiencing mild, moderate, or severe delays in visual performance. These levels, as we have grouped them, categorizes the breakdown in visual efficiency. So on one end of the curve are the people who have focal perceptual styles for learning. In these cases, we observe a fascination of numbers and letters. Within this style, patients also love to line up their items or toys, such as cars or trains. But then as the breakdown in sensory processing becomes worse, level 2 individuals usually find themselves upset with anything involving disorder or the discontinuity of their routines. Motion is a disturbance to them because they can't just move their eyes with the moving target fast enough, and then they find that the object disappears from their view. As we move into level 3 dysfunction, we see a great deal of toe-walking individuals whose perception of their body and the ground is marginally skewed. Imagine being a child standing at the top of a hill. If your depth perception is faulty, you too will rise up to secure your body in balance. And then on the alternate end of the curve are individuals who have global perceptual styles. So these patients tend to make fast movements, both visually and physically. Here we see more cases of reading or learning issues, hyperactivity, eye contact and peripheral side viewing concerns, as well as hand flapping. Neither perceptual mode or style is better than the other. In an ideal situation, focal and ambient processes are working together. So in designing a therapy program for our patients, one main goal is the sound integration of focal and ambient vision. We need both to function parallel to each other in order to achieve homeostasis to our world. To cite Dr. Kaplan in his book, Seeing Through New Eyes, the brain can be compared to a system of roads, with information traveling from one location to another. If the roads are direct and smooth, travel is easy. If construction creates a barrier, however, the highway is blocked, and traffic may be slowed or redirected to side streets. As we say, if vision doesn't provide me with the right information in the right amount of time, I'm either going to reduce my interest in visual tasks, or I'll find other sensory modalities or other means to help me make sense of it all. To remind you, our approach is to view behaviors not as problems, but as solutions to a problem. So if eye coordination is impeding on one's ability to focus properly, and the result is double vision, a person will effectively find a way to turn it off. Peripheral side viewing is a means for monocular vision, eliminating double vision. In discussing hyperactivity, children often see the world as two-dimensional instead of 3D, so objects appear flat, and these children might run toward people or objects or jump without fear. Fast movements to us are indicative of a lack of visual attention. In hyperactive patients, we commonly see compensations for visual inefficiencies by utilizing auditory and tactile senses. So this is the child that runs around touching everything, and they have a diagnosis of ADHD, and then before you know it, they're on medication, when in reality, it could just be that there's a visual problem here. Rocking from side to side, this increases the patient's awareness of their body in space, whereas rocking forward and backwards enhances their scope of three-dimensional space. So depending on really what symptoms the children are displaying, we can really get an idea for what the visual problem might be. Hypoactive children often give up on the visual world. So here is the kid sitting in the classroom, not paying attention at all, and it looks like they're bored, or they might get labeled as dumb or challenged, when in fact they're just having a visual problem, and so they're not able to integrate into the normal world properly. We also frequently see patients who flap their hands, which research tells us excites and or inhibits the nervous system. So the information provided by flapping provides sensory input to tell them where they are in space. But as you increase proprioceptive and vestibular organization by means of stabilizing the visual space, patients can significantly reduce, if not cease, the need to flap. The bottom line here is that we see a cycle of developmental delays, because if left undetected or untreated, an individual cannot explore his or her world efficiently. I just wanted to remind attendees that you can feel free to submit any questions that you might have along the way, if you happen to be thinking of anything while I'm talking. So now that we've begun identifying some of the behaviors that we see have a visual component, what do we do about it? How can we treat the binocular vision and ambient vision disorders effectively and bring some semblance into our patient's world? In the next part of the presentation, I'll outline for you the evaluation process and what goals for therapy include. First, I'll start with the basic outline, and then we can discuss each in greater depth. So first is, I provide an initial evaluation to examine both the focal and ambient visual processes that we've been discussing. A traditional eye exam is completed, and then we also add a complete sensory motor diagnostic evaluation and possibly the Kaplan nonverbal battery of testing, where we would spend the majority of time with our patients. So throughout, I'm determining whether there is a need or benefit for corrective or therapeutic lenses. Corrective lenses would address nearsighted, farsighted, or astigmatic concerns, while therapeutic lenses, or specifically Prism lenses, would address postural, attention, and behavioral goals. When we've determined what help we can be to our patient, we also determine whether or not they make a suitable candidate for vision therapy. So every patient that we see does not necessarily enter into a vision therapy program. Therapy encompasses intrasensory organization and intrasensory motor processing. Sessions are provided here in our office, usually either weekly or bi-weekly, or it can be programmed remotely for those that are out of state who live too far away, or international patients. But most importantly, a vision therapy commitment does require an at-home commitment. And when a commitment is made at home, the patients will excel. Prism glasses are therapeutic, but they are not magic. Our exercises that are prescribed are targeted, and they require practice and repetition in order to see results. Those who commit usually do end up seeing results. So the goal of therapy is allowing patients to make sense of their environment by altering their perception with Prism lenses, and then consolidating the gains with vision therapy. And I'm going to repeat that because I think it's very important. The goal of therapy is allowing patients to make sense of their environment by altering their perception with Prism lenses, and then consolidating their gains through vision therapy. We end up with the creation of permanent neurological changes that translate into a new view of the world. And then in order to monitor the process of our patients, We do progress exams approximately every 4 to 6 months, where we usually expect to see measurable improvements if everybody is upholding their end of the bargain. If we're prescribing the right testing, or the right exercises, and if the patients are doing the follow-through at home, the majority of our patients are very successful. So I want to talk a little bit about using Prism lenses as a therapeutic tool. Prisms, although many parents and patients like to refer to them as magic glasses, really are not magic. They're a medical device and a neurological intervention. So just like lenses that correct for near or farsightedness, Prism lenses transform light and peripheral rays. So what we see happen when a patient puts on a pair of Prism glasses is an instant transformation, not in the clarity of their sight, but in their spatial perception. In one approach or direction of Prisms, the environment can be expanded upon, similar to using a wide-angle lens of a camera. This is great for patients who effectively see in tunnel vision. In another direction of Prisms, attention is inwardized. And this is great for those global learners who have no problem scanning the environment, but they have trouble focusing on what's going on immediately in front of them. So there are many directions that we can implement here when working with Prisms, but those are just two that can create very immediate improvements. Other variations of Prisms can affect head tilts, postural warps, visual field limitation, motor negligence, and what direction is suitable for a person is really determined at examination. As we mentioned early in the presentation, these lenses are not necessarily limited to spectrum populations. So we also see great success with ADHD, CP, Down syndromes, and many other neurodevelopmental disorders. There are really a lot of impressive results that I've witnessed from using Prisms in the last 2 years. We've seen patients who, came in toe walking, and a few months later they're walking completely flat-footed. We see patients who have enormous postural issues. They're slumped over to one side, or their head is completely tilted to one side. And these patients completely straighten up. We have a lot of kids come in here with major sensory processing issues who, after whatever it may be, a month, 3 months, 6 months of therapy, they transform into completely different kids. And this is in many different areas. So there's social improvement, there's academic improvement. There's a lot of providers out there, both eye care and just, general physicians and ophthalmology even, that don't believe in vision therapy. But all you have to do is come into our office and see the patients who have had improvements in their lives. And I mean, there's nothing magic or strange about vision therapy. It's just an alternative treatment that 100% works. Doesn't work for everybody, but for a lot of patients, it's really, it has a transformational effect on the patient's lives, and when we're talking about a lot of these children, it's on their family and parents' lives as well. So Dr. Kaplan has an equation which he has published in a lot of his texts, that space times time equals knowledge. If a person can take in more information in a less amount of time, their ability to comprehend, react, and express themselves in a more appropriate amount of time is enhanced. So in working with Prism lenses, we, number one, address ambient vision dysfunctions and the compensations that lead to certain behaviors. Number two, we address the where am I and the where is it systems in space. And number three, we change the neuromotor processing of the brain. With rehabilitation, Prisms are no longer needed. So eventually, we hope to come to the spot where our patients will perform and perceive equally well as with the lenses. After conducting our evaluations and determining whether corrective or therapeutic lenses are beneficial, comes the discussion of vision therapy. So most parents want to know, if the lenses work this well for my child, is vision therapy really necessary? Can we just get the new glasses and skip the vision therapy? To that, we ask the parents to consider whether good enough is good enough, or if their goal is to remediate the errors that occurred in the child's visual motor development from the start. So if you feel on a scale of 1 to 10 that your child is performing at a 4, and the lenses can get him or her to function at a 7, do you feel that's satisfactory to you, or do you want to really see your child reach a 9 or a 10? So every optometrist will practice the methods that he or she is most comfortable with. Some are going to prescribe lenses and not be a vision therapy provider, while others provide lenses but they don't work with yoked Prism. In our research and clinical experience, Prism lenses begin the process by instantaneously altering perception and awakening dormant neural processes. But in order to truly improve our patients' visual performance, we have to provide vision therapy to create permanent effects on attention, eye movements, depth perception, and spatial awareness. When any individual, child or an adult, recognizes an ease in their day-to-day life, old, unsuccessful experiences and memories are reshaped by newer and successful ones. Vision therapy, no differently than the goals of other developmental therapies, gear individuals whose visual systems were once unsuccessful to shift towards becoming motivated learners, where happier and more social individuals emerge. Beyond remediating the visual inadequacies alone, the goal is to incorporate the total neuromotor complex rather than just vision in isolation. So this involves integrating spatial awareness and creating three-dimensional depth that the patient will learn to interact with more appropriately. It also involves intersensory organization, so putting together movement, vision, breathing, auditory, speech where we can, and cognition so that the preparative movement synergies and the resulting autonomic responses allow the patient to succeed. We also have to ensure that vision therapy procedures are consistent with the patient's abilities and strengths. So we modify tasks as needed, and we want to raise performance incrementally until goals are satisfied. If the procedure is too simple, we have to build it up. If the procedure is too challenging, we have to break it down until success is met. It's also very important that we select appropriate tasks for each patient. As has been imparted to us by Dr. Kaplan, whether they are simple or challenging is probably less important than really walking in the patient's shoes and asking ourselves, what is the demand of the task? Does this task have meaning to this particular patient? Can this task lead to a higher level of proficiency for him or her? So every program that we write, Barbara, the director here, and myself, we do in conjunction with each other and with the thought on the particular patient. So every patient really gets a customized plan that is well thought out for his or her. We don't have a booklet of cookie cutter programs that we give to each patient. There's an actual customized program for each patient, whether they're a child or adult. The result of a visual management program, which is the culmination of testing procedures, lenses, and vision therapy, is that hopefully we have now recalibrated the visual system and compensatory behaviors are no longer necessary or relevant to the individual. The semblance between mind, body, and world is better integrated, and hopefully we can start to wean away the Prism lenses. So I want to just quickly show you that video one more time that we saw at the beginning so that you can see one of our patients. And this is a patient who is a toe walker, lots of issues crossing the threshold, lots of hand flapping. So this is her normal self without wearing any glasses or Prism lenses. And you'll see that she's on her toes, she's flapping, lots of nervous energy, going back and forth, side to side, shaking. Sort of quiets down for a second, but still fidgeting. See, she's having trouble crossing. We're going from the wood to the tile, even though it's flat. It's a different surface, and that gives her pause. And now we put on the Prism lenses in the particular direction that we've deemed appropriate for her. And now she's standing next to the hot stove, and mom isn't pulling her away. She feels confident that the Prism lenses are calming her system. Much less hand flapping. No rocking. Still a little bit, which is to be expected, but much calmer. She's standing flat-footed now. See, overall, you see much more relaxed demeanor. And she's going to walk right over the threshold, doesn't even notice. She goes there, she goes, a little pause, but, jumps over it. So, this is just an example of you know, how quickly she's only had the Prism glasses on there for, you know, less than a minute, and you already see major calming going on within herself. So I've presented much of the clinical work that we provide here at the center, but I'm going to turn the next few minutes over to the director, Barbara, who will be discussing some of the research that has been published by Dr. Kaplan, and more recently herself included.
Thank you, Dr. Alami. Over the last several decades, prism lenses have been studied not only by optometrists, but prisms are actually a very hot topic amongst, you know, people in various sciences, physicists, neuroscientists as well. The ability of a lens to instantly alter spatial perception, the gravity in our movements, and as you mentioned earlier, Dr. Alami, the fourth dimension, right, which is the timing system, all of which influence processing speed, has fascinated researchers amongst these, you know, various professions. Over the next few minutes, I'll present just some synopses on some of the research conducted through the center. For those interested in full-length copies, you know, please feel free to reach out to myself or Dr. Alami or the office directly. I think even if you jump on our website, many of these studies have been uploaded and are available. If there's something you come across that you cannot find in full length, again, just reach out to us and we'll get a copy in the mail for you. In 2010, Dr. Kaplan and I, along with Dr. Steve Edelson of the Autism Research Institute and Drs. Dombrowski, Casanova, Sakazi, who at that time were with the University of Louisville, embarked on a pilot study. Can ambient prism lenses effectively improve the attention of individuals on the spectrum? And it was quickly recognized that participants demonstrated favorable outcomes. So there was a greater and larger study that emerged from that pilot. In the collaborative study, the effects of ambient prism lenses and visual motor training on heart rate variability and behavioral outcomes in autism was examined. Frequently observed in spectrum individuals is the imbalance between the branches of the nervous system. The sympathetic nervous system is activated during times of stress. You know, there we see increased heart rate, blood pressure, and we see a lot of gastric issues, right? So slower digestion and other regulatory processes. Now, activation of the parasympathetic system has the opposite effect. So the body's supposed to go into rest and repose, which is to decrease our heart rate during stressful moments, decrease blood pressure, and allow us for normal digestion, breathing, and other processing. Therefore, deviations and interference from typical autonomic nervous system function, which includes sympathetic parasympathetic systems, can result in gastrointestinal or cardiovascular symptoms. So bottom line is the individual is in constant stress with compromised chances of coming down to rest. So now we're not professionals in gastroenterology, right? But rather the study focused on heart rate variability and the behavioral outcomes, including hyperactivity, lethargy, compulsive behaviors, and irritability. To test the effectiveness of prisms in improving the balance in the autonomic processing, the participants, mainly children, some adolescents, were evaluated for prisms, and they entered into a 6-month vision therapy program. Electrophysiology recordings were taken before the treatment so that baseline could be gauged, and were compared later after treatment courses were completed. And in addition to that, several checklists and questionnaires were administered prior to treatment and were later compared as to monitor the behavioral changes or the lack thereof. What testing determined was a significant decrease in average heart rate, so reflecting improved autonomic balance. The behavioral measures reflected improvements in hyperactivity, ADHD symptoms, and repetitive behaviors. The ABC checklist, which is probably one of the most popular sort of inventories amongst clinicians and educators, showed 3 of the 5 scaled scores were reduced. And specifically lethargy and inappropriate speech were reduced after Prism and vision motor training were implemented. Hyperactivity was significantly reduced when compared to the baselines. Using the repetitive behavioral scale, a secondary scale, we found significant differences in stereotypical behaviors and compulsive behaviors. Using Achenbach's ACEBA, another inventory that many clinicians will be familiar with, we found a significant decrease in rule breaking, and again in decreased ADHD symptoms. I would tell you ADHD symptoms, hyperactivity, impulsive behaviors were some of the most significant findings throughout this study. And that was across the various scales of testing that we used. Prior to the autonomic nervous system study, Dr. Kaplan also published several studies in child psychiatry and human development. There is a great history, again, as we mentioned at the beginning of the seminar, of behavioral optometrists investigating prisms, whether it's related to spectrum cases or learning disabilities. So really there's a plethora of research, evidence-based research, that is available out there. And again, if anyone wanted more information or reading materials, references, we would be more than happy to direct you in that direction. No single profession, we have to say, can treat all of the symptoms that arise with autism. But behavioral optometry does carry a large position in the visual rehabilitation of special needs. A multidisciplinary approach or co-managed care with other specialties, including occupational, physical, speech therapies, as well as neurofeedback and biomedical support, elevates the child's potentials. All systems, we say this every day, throughout the day, all systems must work together. Let's see. So to summarize, we hope you found the webinar so far informative and can walk away considering the main points. Vision goes well beyond 20/20. Look at your children's symptoms as clues. So this is another mantra that we really practice by. Look at your children's symptoms as clues and let those clues guide you to the best solutions. The behaviors are telling you something. It is satisfying a need. Therapeutic Prism lenses allow the individuals to process more information in less time, reducing stress and improving performance. In conjunction with vision therapy, this can be another tool in your arsenal for managing autistic spectrum disorders. So let's see if any questions have come through so far. Again, feel free to continue sending them in. We're just going to sort of review them really quickly. And we love questions, so please send them in.
One thing that we usually get asked as a question is, how long do patients usually require VT? And that really depends on the specific case. Shortest is usually about 6 months, and the longest on average is about 2 years. I would say that the majority of our patients are between 6 months and 12 months. There are some patients that have extremely quick changes, and within a month we are already noticing huge changes, and by 6 months they're graduated, whereas other children take longer depending on their needs. But overall, somewhere between 6 months and 2 years is generally how long.
So one of the questions, and I know when we get phone calls from parents, it's usually the #1 concern. Will my child leave the glasses on? They're very tactile defensive. So the question, how do children respond to prisms? It's a good question. So children who aren't receiving the right sensory input seek the input in other ways. And our children, our patients here, are very bright. When they put the prisms on, they're aware of changes, and changes that they can appreciate because their perception and their world is starting to make more sense. Things are getting easier. even throughout the testing, when I observed Dr. Alami or any of the doctors working here, throughout the pre and post testing, the children, the kids, the young adults, the adult patients, they know that they're, let's say, following a ball easier or walking better. In a few instances, we might have the child severely tactile defensive and they might resist having the frame on their face. But even still, once visual attention is tuned in and life is getting easier, they forget the frame is even on. I hope that answers the question.
Someone is asking, why didn't my pediatrician or optometrist recommend vision therapy? And I think every practitioner really works with the education and experience that they've received and what they're comfortable with. And every practitioner has their unique qualifications. So we present to you what it is that we offer, and I just hope that we're trying to get the word out, and hopefully more pediatricians and optometrists and ophthalmologists will know that vision therapy is a real viable option. I think in a lot of cases it's just not really well known, but that doesn't mean that it's not completely effective.
Here's another question. If we have patients out of state, how do you complete the initial evaluation?
So we really need to see the patient in person. So in most cases, whether or not our patients are international or from somewhere around the country, they will need to make a trip to see us. Luckily, we're located very close to New York City, so a lot of patients will come and sort of make it maybe into a family vacation, or some people just will fly in or drive in for a quick overnight, depending on what they'd like to do. But we're in a great area. There's literally a hotel practically across the street from our center, and they're usually in our office for a couple of hours at least. And we would, if they were from out of state and definitely wanted to start vision therapy, we would get them set up on day one. So sometimes we can do an evaluation and start the vision therapy immediately. So the patient would get an evaluation with me for a couple hours, maybe go out, have lunch, come back, and then in the afternoon, Barbara would do some vision therapy and get them set up with all the equipment that they might need. So, we actually do see quite a few patients from all around the U.S. and also internationally, so we're used to doing home-based therapy. We would prescribe the exercises. We have them all typed up onto instruction sheets. We have a lot of the exercises videotaped. And so patients would get instructions or videotapes, and the parents or the OT or the PT would, learn the exercises and then just do basically home therapy for the patients. And then maybe at the 6-month point or the year, they would return to our site and have a progress evaluation with me. Another question, what is the success rate of the toe walking reduction using Prisms? In our experience, I would say pretty much everyone has some varying level of decreased toe walking. So some people, 100%, they're flat-footed, and I would say most of the children at least a 50 to 75% reduction. So it's pretty, toe walking is definitely the one thing that is easily measurable, and you can visually see changes taking place fairly easily.
Another question that came through, what is the youngest that we have examined in this office? Dr. Alami can speak to it. At the moment, we currently have early intervention patients, so I believe we are one of the first, if not one of the only, vision therapy providers, again, at the moment, offering services through New York State early intervention. And I believe the youngest patient at the moment is about 11 months. He was about 9 months old when he first got the evaluation. But I believe we've examined as young as about 6 months in this office.
Mm-hmm. Yeah, we are also, I'm also an infant seed provider. So for babies between 6 months and 12 months, we provide a free eye exam. no strings attached, and that's through the infancy program, which is actually nationwide. So for any of you who happens to have a baby or know somebody who has a baby from 6 to 12 months, there are infancy providers in every state and probably in a lot of towns. So, you know, if you do have any babies, it is good to get an initial baseline examination. And the American Optometric Association does recommend that every child have an eye exam between 6 months and 12 years to start.
Yes, so as Dr. Alami just mentioned, infancy is a great program. It's offered through the American Optometric Association. What I would also like to refer parents towards, or even professionals, you know, it's really a very dynamic, very powerful group. There's a Facebook group called Vision Therapy, Parents Unite, and I would just really encourage providers, parents, OTs, VTs, PTs, whoever might be listening in now, to jump on that page. Sometimes parents are confused or feel like they're stuck between a rock and a hard place. The ophthalmologist wants to recommend surgery. However, the developmental optometrist, you know, is really sure that vision therapy can help my child. What do I do? And this is just a dynamic group where you'll get answers for better, for worse. You know, you'll have people who have gone through surgery, had great results. You'll have people who have gone through surgery and wish they had done VT. They wish they had known. So, you know, absolutely parents can be the best advocates for this work. It's unbiased, and I would really encourage you to jump on that page. Let's see. Okay. So one last question, it looks like, unless, please send in the questions. We have plenty of time if there are others. Good question. How can I explain to parents, you know, this work? That's a really good question. How do we summarize it in a nutshell?
I think that it's sort of similar to like any other exercises that you might do for your body. So like if you're explaining physical therapy, you're explaining occupational therapy, you know, the eyes are a muscle, and you know, the eyes are attached to your brain, and there's a lot of muscles that make up the eyes, and there are a lot of exercises that we can do that can really change your, you know, your eye-brain connection. And you know, really, it's just an exercise. So vision therapy, you know, it sounds sort of mystical, but it's really eye exercises, and you know, we can get a lot of results.
This is a really great question coming in too. Do you have a good definition of the difference between acuity versus functional vision?
Yeah. So I mean, you know, just because somebody's not 20/20 is not necessarily the end of the world. You know, there are a lot of patients that we see who are best corrected to 20/40, best corrected to 20/80. You know, for an adult, it's sort of, there's sort of an easy cutoff. So like, for example, in the state of New York where we live, 20/20 is sort of a big sort of sign, because 20/20 is what is needed for legal driving. So, you know, if you're 20/20, you can drive. If you're not 20/20, you can't drive. And that's sort of like one label that's there. But that really doesn't tell you a whole lot. You know, just because your central vision is not 20/20 and maybe you're 20/40 or you're 20/80, that doesn't mean that your peripheral vision is not working. That doesn't mean that you can't do a whole host of other things. So, you know, sometimes people are really focused on the acuity numbers. So, oh, you know, is my child 20/30? Is my child 20/40? Is my child 20/50? I don't think that that's really telling you a whole lot of information. That just tells you, you know, is the object in front of my child's face slightly fuzzy, which is not really a huge deal. You know, functional vision, which is something that we can definitely train, and that can be manipulated, is the more important thing here. You know, how well is this person functioning in the world around them? So acuity and functional vision are two completely different things, and I think a lot of people are focused, you know, too over-focused on the acuity side of things, when we really want to work on the function. So, like for example, some of the exercises that we might do for functional vision include, you know, ball playing, bike riding. You know, none of these things are, none of these activities require perfect focal vision. You know, perfect 20/20 vision. But you know, a child who can play ball and a child who can bike ride, cut pieces of paper, you know, do crafts. You know, these children have functional vision.
Another question coming in, what can we as parents do to help spread the word of vision therapy? Are you open to talking to groups? Absolutely. And I think the most important thing, whether it's, you know, professionals or parents alike, is advocate, talk. You know, every one person, I think it was Walt Disney who said, the road to 1,000,000 begins with one. So every person you talk to can be one life that's affected and one life that's improved. So absolutely, you know, we are happy to host these webinars periodically in the office. We also host lunch and learn seminars, open houses. We love to talk.
Yeah, I mean, we're happy to host. You know, we do a lot of things in our community. You know, we've gone to schools and we've presented to teachers and things like that. But you know, even in other states and other areas, you know, the world is quite technological these days. So there's FaceTime, and I'm sure you know, we're a little bit old, so I don't know all the exact technological things. But we would definitely be happy to be, you know, beamed in somehow and talk to groups of people. So.
We'll let Skype work its magic. Let's see. Great questions coming in. Keep it coming. Let's see. If a child has great difficulties of ocular motor tracking because of difficulties with vestibular dysfunctions, is it going to improve with sensory integration as he's integrating his vestibular system, or will he also need a behavioral optometrist or vision therapy?
I mean, I think that a lot of therapies alone will work to improve entire systems, but if you are looking for like a speedier improvement and more efficiency, then vision therapy would be hugely helpful to that type of situation.
Yes.
You know, a lot of the kids that we see are doing many different therapies in conjunction. Like usually our kids are having OT, PT, vision therapy, maybe even speech therapy. So, you know, it's a lot of therapies. And sometimes for parents, you know, too many therapies at one time is too hard, which we totally understand. So, you know, sometimes they might do certain types of therapy for 6 months or a year, and then maybe put a stop on those, take a break, and then, you know, okay, so let's try 6 months of vision therapy and see. A lot of times it's hard to know without trying it, but I feel like, I mean, there are some vision therapy places where you have to buy a package. So, okay, you have to put up, you know, $3,000 or $4,000, and this is what it costs. Whereas our approach is more, you know, we don't really sell a package. We're not even really trying to sell anything here. We give you what we think you're going to need. You pay per session. You can give it a try for a couple of months. If you've tried it for 2 or 3 months and then we feel like you're not getting anywhere, there's no big commitment. So you can leave it at any time. And I think we try to be very transparent about our process here.
And I think just to couple that with what's available in the research, and I want parents to really hear this, and professionals as well. Balance is comprised of 3 systems: the proprioceptive system, the vestibular system, and vision. So you need these 3 systems to come together for good balance. And if I asked you which one of the 3, proprioception, vestibular, or vision, which do you think is the most integral sense involved in balance? Let me see some of the answers come through, please. Like, what would you guys think? Vestibular, vision, proprioception. Which one is the most important in affecting balance? Proprioception, vestibular. I thought it was vestibular for probably the first half of my education and my career. But what neuroscience is saying is vision. Vision is a huge component in balance. And so I think it's great to go with vestibular therapies, sensory integrative therapies. I think if there is some kind of limitation and some kind of a plateau with the success that's being reached or not met, then absolutely a behavioral optometrist should be examining that individual, and vision should really be evaluated. Okay, another question coming through. My son is using his peripheral vision a lot. Prism glasses seem to help him with academic tasks. Should he use the Prism glasses on the playground, outside, while playing? How many hours per day should he wear the Prism glasses?
We actually, in most cases, advocate for full-time wear. So while we're doing therapy and while the patient is under our care, it's full day, all day, every day. And we also find that that's most effective in getting kids not to lose their glasses and just to get used to them. So they wake up, they put them on their face, they go to bed, they take them off, and that's generally what we advocate, so that it's really having an effect on their system the entire time, not just like when they're doing near work or whatever the case may be.
I'm trying to sort through. A lot of questions came in at once, which we appreciate. Let's see. If we missed any, we will go back. Yes. There we go. Okay.
Somebody's asking about recommendations or where to find vision therapists, and so not all vision therapy offices are created equal. There's a lot of differences. I think that one main source for people, at least in the U.S., is the COVD website. So I think is it just covd.org? Yeah. So if you go to covd.org, you could probably type in your zip code and try to find somebody in your area. And not everybody works with prisms in the way that we do. I think there's actually very few centers around the world, really, that work with yoked prism the way that we do. But that's not to say that traditional vision therapy offices are not also helpful if it's easier for you to see somebody close by. Some vision therapy is generally better than no vision therapy.
Okay, I think we got everything, and that takes us through our hour. That was a fast hour. Very enjoyable. Thank you, everyone. Thank you, Dr. Alami, and thank you, everyone, for attending today's webinar. We're going to sort through the questions again. If we missed any, we apologize, but we will reread. We'll sort through this list. But if you have any additional questions that come up, later in your thinking or tonight, or even throughout the days and weeks and months, if you're presented with a case, you have any questions, please feel free to contact us directly, either at the email address or the phone number provided to you here. And again, if anyone is interested in having us speak to a group, please let's be in touch and we will help you however we can. Once you leave today's webinar, you'll also receive a survey on the presentation. We would really appreciate any responses and feedback you'd be willing to provide. You'll also receive a follow-up email in the next 24 to 48 hours with a link to view the recording. In case you missed that, it'll also be posted to our website and our YouTube channel. So on behalf of all of us here at the Center for Visual Management, thank you so much for joining us today, and have a great rest of your day. Bye.